All right, good evening, everybody. I'd like to call the October 11th Community Mental Health Program and Budget Meeting to order. I'm going to start out with our mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. And before we move on to the adoption of the agenda, I just want to remind the board members we're trying something new tonight with the request to speak feature. So if you would like to ask a question, make a comment, hit the little green button on the bottom right and it'll pop up on my screen and I'll get you in the order that it comes in. So with that, move on to the adoption of the agenda. Need a motion to approve? Motion from Lou. Support from Joan. All in favor signify by saying aye.
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 All opposed? All right, motion passes. Next is the hearing of the public. Anybody from the public wishing to speak? You have 5 minutes. 5 minutes. Anybody from the public? Come on up. Give us your name and address and
Thank you for the opportunity to speak to you tonight. My name is Kathleen Kuntz-Pilak. I am a provider for Macomb County Community Mental Health. I am a provider for the company of Creative Empowerment Opportunities. Its DBA is Creative Employment Opportunities. I've been a provider in the county since 1993. We are a CARF accredited agency with community services and currently are servicing 338 individuals that are directly funded through Macomb County Community Mental Health. So we do provide quite a bit of services in our vocational and skill development services for the citizens of the county. We provide services for the intellectually disabled and individuals who are in recovery from mental illness. In February 2017, I stood before the board, the very people sitting here, some of you are newer, and at that time I made public comment that providers were unable to withstand another 2% budget cut from Macomb Oakland Regional Center. At that time, the board had, let me slow down here, thank you, so that we couldn't take this 2% budget cut. The time had come for the board to take action on maintaining, on why we're maintaining duplicate administrations in the county, and that the Medicaid dollar could be used more efficiently to ensure services to our citizens and families of Macomb County. I want to commend the board and I want to commend Macomb County Community Mental Health and all of their work and eliminating a lot of those duplication of services. They've done a phenomenal job and there should be great acknowledgement given under the leadership of John Kinch and especially Christina Ritz and making sure that the transition and looking at how we're eliminating some of those duplicate services. So there is more Medicaid dollars to be servicing the individuals that we serve and paying those staff that provide direct services better wages. But I come before you because during the transition that it has caused a drastic budget cut to the agency I represent, Creative Empowerment Opportunities. So since April of 2017, our MORC, we have been cut because in the transition, transferring all the MORC folks to Macomb County Community Mental Health by 16.1%. I came before you because I couldn't take a 2% budget cut. Instead, I got a 16.1% budget cut. And this is because they did a weighted average. So what really needs to just take place is there needs to be a correction on how they're weighting the weighted average. So right at this point, because of this cut, and total lost revenue since April for CEO has been $71,516.85. This is a significant amount of money for a nonprofit charity that had a budget based on what MORC was paying us at and versus how our weighted average came into Macomb County CMH. With that being said, it's causing the inability for our agency to replace vehicles, to be able to get people out into the community for the home and community-based waiver. It is also causing complications for us to be able to retain and recruit staff. With that type of ongoing budget cut, you can see that will multiply because we're 6 months into this transition, so everybody can do the math on that. That'll be $141,000 roughly. If this isn't corrected. So I'm coming before the board today to ask you to please consider, I know it's going to be coming up in future agendas, that the weighted averages that are being utilized, that they need to be re-looked at, they need to be recalculated for the providers. The providers are in a great need for us to have an increase on the monies that we're receiving. I know you're all aware that minimum wage is going up. That's a mandate by the federal government. That also that 50 cents an hour increase that has been set forth by the state, but has been undetermined on how community mental health is actually supposed to give that down to the providers. That's still also pending. But please consider when you talk about the weighted averages upcoming that we do need to have that corrected, not only for CEO, but for other providers. Is there any questions? Okay, thank you for your opportunity to speak with you.
Thank you. Anyone else from the public wishing to address this body? Going once, going twice. All right, seeing none, we will close hearing of the public. Next is a request to approve updated policy retitled Policy 10450 EPHI Security. John, you want to speak on that?
The next three items on your agenda are related to protected health information and or access to our electronic medical record. And Kimberly Cope, the compliance officer and policy officer, continually brings those policies up to date relative to state and federal mandates and local mandates as well too. I don't know, Kimberly, you want to speak to some of the changes in them? I think the board was provided with the policies in advance and also a brief narrative that spoke to the changes, but I can call on Kimberly real quick. Thanks.
So there's three policies that were updated. One pertains to just updating our definitions and how we protect the protected health information to sequester records of consumers who have, been in the newspaper or who there's a high-profile case that involves them, so that we can protect that health information. So that was updated in policy 10-450. The other two policies relate to how we access the electronic medical record, and it puts a process in place that's more formal so that everybody can understand what's expected of them and the parameters that are involved with accessing the medical record. So if there's any questions, I'm more than happy to answer them for you.
We'll start with A. Does anybody have any questions on A?
Mr. Chair, is she talking? She's going to talk about all three.
You just gave a brief overview for all three, correct?
I did.
Okay, we'll start with the first one. If anybody has any questions on the first one.
So the first one is the one where we updated to sequester consumer information if there's a high-profile, newspaper article or news article about a particular consumer, so that it's only accessible to particular staff, so that it's not easily accessible to a multitude of staff. It helps with the curiosity factor.
Any questions? I don't see any. Joan, you can speak. Go ahead, Joan.
Of policy 10-450.
Through the chair
Yes,
to
Joan.
Kimberly. The last page where they have all the category A and B,
Yes.
is that all our workers? Is this what you're telling me? What's
Yes.
this?
This is a general categorization of all of the staff at Community Mental Health.
At our building?
Throughout the system at all of the various buildings, including administration.
But you have more case managers than just this here, right? I know you have an executive director.
Right, there's more case managers, but these are the classifications when there's a job posting.
Okay,
So that's what's listed here are the classifications that we use for the job postings.
okay. That's what I was taught. Thanks a lot, Kimberly.
Anybody else have any other questions on item A? All right, seeing none, I'll take a motion to approve.
I move to approve.
Motion by Joan,
Support.
support by Marilyn. All in favor signify by saying aye. All opposed? All right, next is item B. New MCCMH MCO policy 10442, focus access management.
So this policy and the subsequent policy 3-016, in a lot of ways they mirror each other. If you see a 10 in front of the policy number, that means that it applies to MCCMH staff. And chapter 10 of the policy manual applies to all MCCMH staff. So this policy applies in particular to MCCMH staff. So the difference that you'll see is in the procedure section. We have specific procedures about how our staff internally will access focus. And in the next policy, in 3-016, you'll see how the contract staff would access focus. So that's the difference basically between those two policies, is how they request access to focus. Internally, we have more mechanisms to control for the classifications and the access that they have, whereas with the contract providers, they provide us the information, the job description, the request. If we need more information, we get clarifying information from them, and then we're able to put them in a particular designation that allows them particular access. So those are the differences between the two.
Anybody have any questions? All right, seeing none, I'll take a motion to approve item B. Motion from, I think, Linda. Support from Lou. All in favor signify by saying aye.
Aye.
All opposed? All right, next is item C, new policy 3-016, focus access management, contract network providers.
So this is like the previous policy. It's how they access the focus system, but it applies to our contract provider network. And so the procedure section is specific to how the contract providers access the network.
Thank you. Any other questions? Nope. All right, I'll take a motion to approve item C.
Move to approve.
Motion from Marilyn.
Support.
Support from Joan. All in favor signify by saying aye.
Aye.
All opposed? All right. Thank you very much.
Thank you.
Moving on to lease agreement residential facility A.
We discussed earlier that we're going to have both Tracy and TJ approach the mic on these items as well. And so they can kind of highlight for you why you're going to see a little difference in the lease agreements than what you're typically familiar with and how they read on the agenda. So Tracy has a mapping of that so we can all be on the same page, and also a rationale why you're going to see a little different information when we sit in this type of forum.
Yes, as John stated, you can see that they're labeled as A through E on these agreements. In the current board sync system that you're now using, our understanding is that when we put the agenda item on there, it would list the address of the group home. So we wanted to really for you to establish a protocol, just pointing out that you're pointing out, giving the address of where our consumers are residing. So we just wanted to see if what your preference was to go ahead and continue to list the address, or to have this system allow us to do confidential. It would still fall under the Freedom of Information Act, and they could still request the information, but it just wouldn't be publicly posted on all the agenda items that are available on the internet.
Is there any discussion on this? Lou, you're on my board.
Actually, I have some questions that relate to all of these and to all of our group homes. As I was going through these, I noticed that with these four in particular, with the exception of Harrison Township and Chesterfield, where the taxes went down, the reason rates went up is the insurance costs. Now, I noticed back in 2008 when we had the negative impact that hit us, subject to correction, I don't necessarily recall taxes being down so specifically when we renewed leases where it made any difference. But I do know now what's happening is that as the field recovers, the system is being hit with 1 to 2% tax increases annually, but our insurance rates are going up. My first question is, why? That doesn't strike me as necessarily relevant. My home insurance literally hasn't changed from 2008 to 2017 on my policy situation. So I'm wondering why the monthly insurance and the annual insurance is going up. And what are we doing about it? For example, have we changed the insurance requirements that we find necessary on the homes? If we haven't, why are the prices going up so significantly across the board?
We have not changed the insurance requirements.
Okay, so
we've-
then theoretically, the prices should be more stable than I'm picking up when I've been looking back at all of these that we're doing. Significantly, every time you bring one, it has higher insurance costs, almost as a given. And taxes, 1 or 2%, as I said, Harrison and Chesterfield were down. But this doesn't make good business sense from my viewpoint. If we haven't changed the requirements for insurance and the value of the home theoretically went down and the insurance continues to go up, that would seem to me to be something we ought to be looking at. Had we ever thought, for example, and I know it would be difficult, and I know it would be complicated, of bidding the insurance and providing that the homes participate in what we would bid as a group policy across the board. I'm sure if we thought of doing it on that basis, we could really bring down the insurance monthly costs and the annual costs if we did it on a big bid provider basis and made it a requirement that they participate. But that's beside the point. I'd like you to think about that. But what I really want to know is, why are we just picking up higher insurance rates every single time without questioning it? And I don't mean that as a challenge. I mean that as a significant factor that every single lease renewal has higher insurance rates attached to it. Now, that's not correct. That can't be. Your turn.
We have noticed that the taxes have gone up almost across the board.
Well, they will.
But incrementally small.
1 or 2%,
Yeah,
TJ.
the
Yeah.
insurances, mind you that all of our homes are different. So they run the gamut, whether they're wood structures, brick structures, two-story, single-story, fireplace, all of those variables come into play. And we have, as we've started to see these increases, we have fought back against particular landlords. As you know, we are now capping the insurance for the next 5 years. When a lease comes before you, that number is capped now. We no longer are going to cost settle that amount. It's a capped figure because we saw that increase starting to go. And we were losing our leverage in terms of negotiation, and this was one point that we could still gain some ground. That's why we capped them. But for us to fight an industry that's incrementally increasing, I don't know if we can. I don't know if we could do that.
I have noticed the cap comment. What I haven't been able to do is, because I don't really know what the total insurance cost is against the unit, that if I multiply that number out, I don't know where it takes me in relation to what the actual insurance costs that they're attempting to provide in the contract. So I can't work with that number, but I have noticed what you're doing. But I don't know how relevant or what the relativity of that capping is in relation to the insurance costs. I understand that if I were to insure a 3-bedroom ranch against a 4-bedroom colonial, that the insurance consideration is going to be different. That I, of course, understand. But the fact that with property values down per se to 2008 levels, where now, from a taxable standpoint, the county and the state is recording 1 or 2% increases annually, so that's a tax increase that you can't do anything about, because that's going to happen until it gets back close to what the market value would have been, say, in 2008. That's what's going to happen. But the insurance rates should not be increasing when the market value, theoretically, of the home has been reduced so significantly. So that's the question that I'm asking of how you're exploring. Setting a cap rate doesn't tell me how that number is significant to the total cost that the owner provides to you in negotiations, where you're capping his insurance against what the actual cost is that he's telling you it is. So I'm just saying, I think that, without offense, actually, I think that's a loose end that we ought to be looking at a little more significantly, because I think, frankly, there's some leakage there that shouldn't be occurring. Now, that's, I just mean to say, I think you ought to be looking at that in some fashion of how another way of providing that insurance might be better for us, especially since we're faced with such negative monies that come in. Any savings we can occur without affecting the value of what we do is significant. That's where I'm going with this, and I just hope you think about it and perhaps can come back at another meeting or two with something that would address that. Especially, I would like to know how you cap a value in relation to what the landlord tells you his insurance costs are. In other words, if he says they're $10,000 and you cap it at $1,000, then what you're saying is you're only going to pay 1/12 of the 10. Is that what you're saying on a monthly basis?
Well, we do seek proof of insurance in a declaration page that shows that they meet the standards that are set forth in each of our leases, that they're meeting that. And then we take that average over the course of a 12-month period and break it out in the monthly cost. So we do seek that proof that they are getting the insurance
I would
and paying
expect that you
insurance.
do that, but I don't understand.
Lou, let him finish.
Pardon?
Let him finish.
I was.
Okay.
I assumed you were. I didn't mean to cut you
No,
short.
that's okay.
Okay. But if the cap number is 1/12 of what he presents as the actual charge his broker is telling him the insurance rate is, we're not doing anything except dividing it by 12. That doesn't cap the rate. That actually concurs with what the rate is that he says. That's not a cap, that's a concurrence. I don't mean to beat that to death. It's one of the reasons why I don't understand what you mean by capping. You're not capping, you're agreeing. You're just dividing the bill by 12. So that's all that occurs there. What I'm saying is, are we asking why the insurance is as high as it is in relation to the existing current property values? That's the question I think we ought to be looking at internally, because it seems to be going up consistently. And if that's the case, and I have an individual broker, I might have some other deal going or something, and I don't mean to suggest anything nefarious, But I'm just saying our due diligence, I think perhaps ought to be concentrating on that because it seems to me to be disproportionate to what the current market is and how it's progressing. The taxes, I understand, that's exactly correct. 1 or 2% is what's happening across the board, and that's going to happen annually. But the insurance should not be coming up higher every single time. And it projects for 5 years. So if that's the case, my second wonderment would be, how does a real insurance person predict what the insurance cost should be on a particular facility 5 years down the line? My insurance company renews me annually. Doesn't give me a charge on year 1 that I'm going to pay on year 5. You got to be kidding. I mean, if that doesn't trigger a signal, then I think we're missing some signals here. And I'm just suggesting perhaps administratively, we might want to take a look at that. I don't think we're looking at it appropriately. Fair enough, just my view with this. It seems to have caught up with me, so.
We can absolutely take back and come back with some ideas and solutions. The way we currently do information is we look at the averages as an indicator. So as an example, we try to compare a similar size home, similar structure in a similar area, and if the average cost of that particular insurance is $100 a month as an example, and the landlord comes to us and says it's $170, even if that's what the insurance agent says, we question it. So that's not the perfect system in any way, but that's one of the ways that we try to look at what is, of our 108 homes that we lease directly, what's the overall average?
I'm not challenging what you're doing. I'm merely suggesting that over a period of time, as I've observed these requests, it's come to my attention that the insurance part of it does not significantly seem to be keeping pace with negotiations, tax increases, property value, and so forth, especially when you extend it 5 years. Now, when you buy your home insurance, I guarantee you, you get a 1-year quote, you pay it, and you get another quote the second year. And significantly, your insurance, if you haven't changed any of your requirements, is pretty much in the same ballpark. Really, it's a $1.19 difference if it's that. So an insurance person who tells the owner of a home 5 years down the line, it just doesn't make sense. That's not how it works. So I'm saying theoretically, I think this is something we should be looking at a little more acutely. It's a suggestion. I think there's some flexibility here that strikes me as inordinate. And I don't want to go further than that tonight, but okay. And I'm not questioning what you're doing. I'm merely saying I think this is something that ought to be looked at a little stronger.
Thank you, Lou. We have a few more questions. Susan.
Thank you, Mr. Chair. Through the chair to staff, I think the question was about whether we would want to display the address on the agenda. So it's my understanding that our agendas our whole packet is published and the address is in there.
Well, yes, and that's, again, the protocol you've established. My general understanding of the board sync system is in this package, all your attachments, which would list the address, I checked confidential, which meant, from my understanding, everyone on the board and any staff member who has access to board sync could see all the attachments, which includes, again, the address. Now, it's still foilable again, so somebody could request it, but one choice is to, on the agenda, put the address and make it publicly accessible with all the attachments to everyone. Another choice is to list the address but still make all the attachments confidential, or you could, again, have it the way we have it, which is the most conservative until you give your preference, is not identify the address on the agenda and keep all the attachments confidential.
So I like the idea of masking the address for the safety of the consumers, but I don't like masking the entire lease agreement. And the reason I say that is I think the public has the right to know what insurance or rent or whatever we're paying for these properties. And I think it's okay to list like what community they're in. So like if you have a home in Romeo, you know, you'd say Romeo, but you wouldn't give the street address in Romeo. That way somebody can get an idea, is this property value suitable for a home in Romeo? Is this, you know, insurance, tax base, whatever it is for all the rest of it? So is there a way to mask it just the street address?
Yeah.
And the documents would still be accessible and viewable?
I'm sure there's lots of ways we could, you know, cross out certain information if that's how we so choose it. Or you can, from my understanding, have attachments that are confidential and attachments that aren't confidential.
So
Maybe just to be
I'm not
cognizant
in
of it.
favor of making the attachment. I don't want it to appear that we are hiding anything. Because remember, if you make the whole lease agreement confidential, the public will not be able to see. Well, I will hide the address, of course, which we want to, but then they won't be able to see who the owner is. They won't be able to see what the rent payment is. They won't be able to see what the tax payment, you know, and they won't know what the square footage is, what community it's in. They won't see anything about that property. And I think that that's going too far.
I think we could simply take off the address.
Yeah, so I would like it, just redact just the house number and the street, but leave the city and the zip. So like, you know, you have a general idea of what community the property is. And I think if that's feasible, I think that is reasonable. And then, like you said, if somebody really needs to know what the street address is, they would submit a FOIA and we would release that information. It's certainly available to the public, but then there would be, if there were any, you know, poor, you know, if there were any action taken in the home or something, like if there was some vandalism or something like that, then there might be some paper trail as to who was wanting to know what that home was. You know what I mean? I think that would help a little bit. I don't think we've had any problems with this, but we're just trying to be a little proactive to avoid things, right?
Correct.
Okay, so in answer to your question, that would be my preference, and I would welcome anybody that would disagree with that.
Just to be clear, just strike the street address.
Just the street address.
But we would have to strike that or retract it throughout the document, because every page, as you can see, you'll see.
And that's fine.
Okay.
That's fine. I would. I'm sorry, who's asking that question?
We can redact
I
any
heard
of the
I heard a
information that would
voice,
be
but I don't know who was asking.
any identifying information of the address or associated with the
Oh,
address.
okay. Yeah, so I think anything, you know, but like I say, I think we need to leave the city and the zip code. So, so that people identify the parcels. So that would be my preference, and I'm open to suggestion of other board members if they think differently. Thank you.
All right, next we have Nick.
Yeah, I think you answered the one question. We're concerned about releasing this information, though we've done it for years. Have we ever had any problems?
No, I think what, is a new protocol, this is a new system. When you go online on the county website, you're gonna see the agenda, and right up front, you're gonna see that. As you know, anyone can come to a public meeting, and they would have seen it in the past.
Sure.
So if there's no concern there, and you don't wanna change that in any way, we completely will
Well,
move
I
forward.
think Susan's approach makes sense, that you eliminate the exact identifier, but not eliminate more than you have to. Quite frankly, it raises more questions the more you redact as to why. So I agree with her. I just was wondering whether we had any problems in the past. In terms of the insurance issue, how are you determining the cap?
So TJ, you can jump in, but the landlord provides us a document from the insurance provider, like you said, the declaration page proving it meets the standards.
Right.
And then how much it is for that year. So it's
Yeah.
$1,000 as an example, we then divide by 12. But remember, since we're capping it, whatever they say it is in year one, it will be in year 2, 3, 4. And then at
And-
the end of the
and
year,
5.
because this is new for us, we still reconcile. So in other words, again, if you told me it was gonna be $100 a month, and at the end, it really only cost you $999, you still owe us the dollar. But
Okay.
if it was $101, then we don't owe you anything.
So essentially what we're doing is capping the 4 or 5 years at the first year price. So we are likely realizing some savings. In terms of the value of the property, which is one of the things I think Lou was getting to, because obviously the insurance is tied to the value of the property. I am assuming that the taxable value, because taxable value went up 2% doesn't mean the market value went up 2%. The market value may have gone up 10%, which could explain some of the difference there. But I am intrigued with Lou's creative solution of trying to leverage our marketing with the insurers by looking at trying to use our market power, basically, to keep the overall cost down. That would save not only us dollars in insurance, or could save us dollars, but would also save the providers dollars, because we may get a better rate by going across the board. So I think it's at least worth exploring. Are these properties taxed as businesses or as homes?
It's residential.
Single-family residential.
So they get the homestead property tax exemption.
Not if they're not
Not the
tied down.
homestead property tax exemption, but I'm sorry, I meant the lower rate. They don't pay the school education tax. They get
They do.
the addition, the 16 mills that a homeowner does not pay, so then they're taxed as a business, not as an individual.
In the tax receipts that we get, and it is another set of proof that we look for, is a paid tax receipt. We do see operating millages, we do see schools. we do
Well,
see
of course, there's operating, but there's a school, there's a state education tax that is assessed to business property, but not to individual homesteads.
I don't know if I can answer that right.
Yeah,
now. I'd have to
I'm
research
just
that.
curious as to whether they're
I'd have to research
they're
that.
taxed by the local
We
units of
do-
governments as
There are some
business.
communities that have that levy certain, like trash in some communities. We remove those, but they're all operating expenses are part of the overall that we pay.
Yeah, but there's two different standards as to how you apply city property taxes, school property taxes under Proposal A. If you're a business, you pay the state education tax, which is 16, 18 mills, I don't remember which. It's a substantial amount. If you're an individual homestead owner like I am, on my homestead that's exempted. If I had a cottage, it wouldn't be exempted on the cottage, but it's exempted one time. I'm curious, and I don't know the answer to this, that's why I'm asking, as to how these properties are treated, because the definition, because of the way the state law definition is, whether they pay that state educational tax or not. You don't have to answer it now, we just double
We
check.
can check into it. My general understanding would be they would be similar to your cottage example.
Yeah, because there's multiple. Because there's multiple residents, I'm not sure that they qualify for that exemption. That's just a matter of curiosity. And it's something to think about for the future with the legislature. But I do think the idea of looking at a way to try to leverage our buying power with insurance companies is worth exploring.
Lou, did you have a quick point of clarification or quick point of
I
clarification?
just wanted to indicate that they're taxed as a residential home, and as far as school taxes are concerned, they're taxed at the school level of the district in which the home is. And that's part of the tax bill that you get. And that I know to be real, so.
Thank you, Lou. Just as a quick tidbit, the Board of Commissioners, really the only thing we have for confidentiality purposes is when we go into closed session, we talk about pending litigation. I think that's one of the only things that I've come across so far that is kept confidential, but I don't have a problem with removing the house number and address. And I think somebody from the audience mentioned parcel number as being included in that. That would be part of it as well, but just throwing that out there. Joan, you're next.
Thank you, Mr. Chair. I agree. What do you mean we're going public with this? Tell me. I mean, for years we have did the same thing. And nobody has come up and sued us or anything. Have they, about their addresses being out
I
there?
think we're just trying to look out for the consumer in identifying where they live. That's really all we're trying to do, is give them a degree of privacy of the home that they live in.
Where is this going to be? You mean if I can go on my computer at home, I can bring this all up? What are you telling me?
Yes.
I mean, for the average person.
If you went onto the Macomb County's website and
Okay.
viewed the attachments and agenda items, much in the same do the Board of Commissioners, however you list them on this document that you see, you would see, if we put the address of that group home. So you would see it as the agenda item. Now, when you came to the public in the past, you would see that address, but it was a little bit different because you were only having people see who came to the meeting or specifically requested copies of the agenda.
Oh, I see.
That's all. It's just, it's an expansion, and it makes the residence address of our consumers more easily accessible is our only pause, and that's why we're seeking your guidance.
Okay. And you're talking about business or homes. Well, you know, it is a business when they are having consumers in their home. What are
Technically,
you talking there?
technically, it's still identified as a single-family residential setting.
But it is a business. Okay, thank you.
Linda? Go ahead, Susan.
It would be, it's my understanding that it would be redacted through all of the material. If we wanted to know what address it was, let's say I wanted to go and look at the home or something like that, I would just call staff. They would provide me with the address so that I could go look at it. If someone from the public said, you know, item A, whatever number it is, you know, I don't know if I agree that that's the price that should be paid for a home in Romeo or wherever it is, and they could submit a FOIA, and we would provide that address to them. So it is publicly accessible. We're just not broadcasting it out on the internet so that anybody can just go look at it, because we just don't want to invite any issues. It has not been an issue, as I understand it. Yeah. But we're just trying to head things off at the pass, trying to keep privacy issues, is my understanding.
John?
It's a good conversation. We had this meeting prior to coming to the board here, just, believing and taking the opinion that maybe there's a good opportunity for a little bit of change in how we practice business. There was no ever any intent to minimize or not be transparent to the board, the community, and knowingly that all our information is FOIAble, but in protection of our consumers who live in group homes in addresses that, right now you can say nothing's ever happened. Would you have a different position right now if something did happen where somebody went to one of our group homes and did some, some nasty things in our group home? Would you have a different opinion right now about using the group home address? That's all we're saying. So it will follow the direction of the board, whichever way you want to go with it. That's fine. Thanks.
Lou on the next round? Or is that from last time?
About the fact that these homes are a business. They are not. They are, by state law, single-family homes. When these homes were first proposed years ago, and they began to appear in neighborhoods, communities objected to group homes because they said they were a business being instituted in single-family residential neighborhoods. So they objected to allowing group homes to exist as they presently exist today. The Michigan legislature passed a law that said they were not a business, they were single-family homes, and the occupants, 4, 5, or 6, were to be considered as a single family. And therefore, they are not a business, they are residential homes in residential zoned areas by state law. And that's the short version of the story.
Thank you, Lou. All right, we are still on the lease agreement residential facility A.
I make a motion that we pass this home.
All right, we have a motion to approve. Is there a second?
Nobody's going to second. Jeez.
Support from Lou. All in favor signify by saying aye.
Aye.
All opposed? All right, motion passes. Next is the lease agreement for residential facility B.
Support.
Motion from Susan, support from Marilyn. Anybody have any questions on this one? All right, I don't see any. So all in favor signify by saying aye.
Aye.
All opposed? All right, moving on to lease agreement residential facility C. Need a motion to approve. Motion from Nick, support from Lou. All in favor? Sorry. Susan, you're on here. Discussion.
So when we move to this, when you're going to call them A, B, and C, D, just make sure that you label the backup pages A, B, C, and D, because I'm having a hard time keeping them square, which I used to do the addresses.
Yes,
so,
good idea. Thanks, Susan.
So just to point that out. So this one, interestingly enough, seemed to have a lot of issues, structural issues, and it appears that they've been resolved, or you wouldn't be bringing it forward to us. But I have concerns that it was allowed to get into such disarray, right? This is item C, if I'm remembering correctly. So can you let us know what kind of a program we have this on to make sure that it stays in good repair?
Sorry, Susan, there's two perspectives here, from the
Okay.
landlord
Uh-huh.
and from the provider.
Okay.
And we're looking at leasing this home and reestablishing a contract with the landlord. And I can assure you that the landlord has taken care of all of the issues here. The other issues are provider issues, and those go back to a little bit of budgetary concerns. They go back to a little bit of staffing concerns. And we are taking measures to address those both on our direct operated side and on our MORC operated side as well. So all of those concerns are being addressed, and if they appear to you to be structural, I assure you they're not structural. They're more cosmetic, most of these concerns. A broken window is cosmetic for me, but there's not foundation issues. We don't have crumbling roofs, that sort of thing. These are all worthy of a lease from the perspective of this contract with the landlord.
Okay.
How the home is treated on the inside goes to the provider in most cases.
Okay. Okay, thank you.
And those issues are being addressed through
Okay,
other measures.
thank you.
All right, I don't see any other questions. So we have a motion and support. So all in favor signify by saying aye.
Aye.
All opposed? All right, that one passes. Next, lease agreement residential facility D. Motion from Susan, support from Joan. Any questions or comments? All right, seeing none. All in favor signify by saying aye.
Aye.
All opposed? All right, that one's approved. Lease agreement for residential facility E. Motion
Support.
from Joan, support from Marilyn. Any questions or comments on this one? All right, seeing none. All in favor signify by saying aye.
Aye.
All opposed? All right, that one's approved as well. Thank you.
Thank you.
Next is approve the contract with Personalized Nursing Lighthouse Incorporated to provide SUD residential and subacute detoxification from October 1st, 2017 to September 30th, 2018 for the Macomb County Office of Substance Abuse. Come on down. Take a motion from Susan, support from Joan.
Good evening. Very simple. We needed a residential facility. We didn't get one in our RFP, so you gave us the authority to go out and try to find one without doing the RFP. We found one. It's very suitable. We scored it just like we would an RFP if we had others that they were competing against at the time. They scored very well. We checked out their experience by contacting my colleagues over at the 3 other, whatever we're called now, substance abuse entity. They raved about it. In fact, they gave us that as a suggestion to contact that program. They're opening up a new facility, not a new facility, but a revamped facility at 13 in Shaner in Madison Heights.
13 in Shaner?
Oh, God, you're right. Well, that's in print. But I'm telling you, yeah, there's 13 in John R. I didn't look, so I'm off a little bit. And it's a very suitable facility. They have an excellent track record serving our clients, and with broad issues. And so I'm bringing it forward to you to have us engage in a contract for residential and substance abuse detox services.
Oh. I can't press my thing.
Got Linda and then Joan.
Randy, could you tell me about the program? When you say detox, how many days and
It's
what
a
we're
typical
purchasing, what it'll look like for the customer?
program in that respect. It's 3 to 5 days for detox services. That's what all of our providers, residential or detox providers, do. And then residential will be 21 days, up to 21 days, with the option of, in all cases, if there's a demonstrated need for additional services, we provide that, or we will pay for that. So, they have specialty services available for women at one of their facilities. So we could, if we wanted to, they could cover some of the overload on some of that, as well as it's a men's facility. But they also have the capacity to, in this facility, to expand if need be. So if we need to have additional beds down the road, they might be able to, they're taking a risk because they're establishing a new facility in a really kind of risky environment right now. And anybody who's willing to establish a new facility when the threat of losing Medicaid expansion, the Healthy Michigan and Affordable Care Act, they're doing that. So they want to make sure that they have enough. We'll give them enough beds along with, we won't be doing it alone. Our colleagues over in Oakland County will do it, and Detroit will send people there too. But anyways, I just very impressed with them. I walked through the facility. The programming is all very well. If you ask them what professional nursing light, they call it, services is, they have for each letter, and I can't remember what they mean for each letter, they have, it spells out what their philosophy is for serving clients. If you want that, I can get that to you at some point too.
Thanks.
Okay.
Joan?
Through the chair. Of all Macomb County, you couldn't find anything in Macomb County.
That's why we're looking out there. We've got, you have 2 facilities in Macomb County.
Where are they?
With Share Macomb, which is out in Warren, in your area. We also have Salvation Army Harbor Light, that's in Mount Clemens.
Yeah.
That's Macomb County. But Macomb County's never been a home for residential treatment. I think traditionally you haven't had the demand for it here in Macomb County. Now you do, but you don't. So trying to find facilities. Remember, we have Eastwood out there who closed down their residential facility, and they were housed with Share for the last 2 years.
Where was Eastwood?
Eastwood was, they were in Share House out in Warren, and which I can't remember the name of the whole facility. It was a psychiatric facility. Pardon? Yes. Glen Eden. Thank you. That was the old name, but that's a facility everybody recognizes, except apparently me, but I can't remember it. But,
So you said you walked through it. Is it open now, or is it just...
No, it's not open now. It's a medical psychiatric facility that was a privately run organization. It was owned by doctors, and it has, I think, I don't know, but it has well over what they're contracting for. We're asking them for 36 beds, 6 detox, and the other 30 will be regular. But they have a number of other beds that they could take the whole facility over if they were so inclined and could afford doing it.
Well, you be sure to get patients. You're not going to be like on Garfield. We don't have the patients out there.
We have enough patients in this county right now. That's why we're researching it, because we don't have enough beds that we contract with right now, which is why we needed to go out and find them.
Okay, thank you.
And so they will be up, they're expected to be up and running by December.
Okay, thank you.
You're welcome.
Any other questions or comments? I don't see any. All right, we've got a motion and support. Oh, Linda's on there. She snuck in. Go ahead, Linda.
It's on a different subject, though, but it's Randy, so how do you want to do that? I didn't want him to get away. I just wanted to say that my understanding is that since Help Not Handcuffs started in March or February, they've had 500 people go through there. 90% of them have been placed in some kind of treatment, and many of those we fund through your office. So that's a good record. That's incredible, really.
Well, I give Helen a lot of credit in terms of getting that set up, and our access center has been very responsive in terms of handling those requests for coming in, because it does put an extra strain on our system. And you've got, because what you've got is this whole flood of people that are coming in and that they're promising they're going to get into treatment that day, and they'll have an angel waiting for them. But then, so that kind of deters some of the other people that come through more traditional means, which is basically calling them up and say, I need treatment. And so that kind of, it's puts a stress on it. Plus, but what's happening too, as I mentioned to you earlier, is that the people that are coming through there, a large number of those people aren't staying. They're coming in, they're staying overnight, maybe 1 to 2 days in detox, and then they bolt. And that's not what we want to see happen with our folks. We want to see them come in, go to detox, then go to residential, and then ideally then transfer to outpatient. So that's a piece we have to look at and see what we can do to make that better. But it's a group effort.
All right. No other questions? All right, we have a motion and support. All in favor signify by saying aye.
Aye.
All opposed? All right.
Thank you.
Approved. Thank you. Next is a receive and file state fiscal year 2017 validation of performance measures for Region 9, Macomb County Community Mental Health Services. John, did you want to speak to this one?
Yeah, sure. Thank you, Mr. Chairman. Just so you're aware, earlier today, this document was provided before the Board of Commissioners. I really didn't go through it with them in light of time, but they did have it, as well as the next document that I do want to spend some time on. This is a report, a validation of performance measures for the PIHP, and if you look through it, it's just an overview. The Health Services Advisory Group, they came in here from Arizona back in July. They took a look at how our system of care is operating, and it's pretty much flawless throughout. I don't think you're going to find too many, if anything, that's in here that really speaks to a shortcoming on behalf of the PIHP and how we manage our information systems, our performance indicators, our reporting, the evaluation of our system, data integration, data control. As you screen through that, maybe you can take a look at that. Performance indicators and documentations, the PIHP strengths, eligibility data system, behavioral health treatment episodes. All of our reporting is fully compliant. And, if you get to page 12 there, there's no hiccups at all along the way. As far as you get to page A1, first attachment, accuracy of all the data transfers, accuracy of the file consolidations, the data extracts, the deviations or derivations. There's nothing in there that's flawless. You go to page C1, It speaks to some of the indicators. Remind you, or at least guide you and let you know that the indicators are only for the first quarter. So all the numerics and statistics you see there relative to timeliness of service is really related to the first quarter, October 1st of 2016 through December 31st of 2016. So it's a year ago that all of these indicators there. But it shows that, you know, like an emergency, if a child shows up any place in the state of Michigan in an emergent situation, a child or adult, we have a responsibility to render a disposition on where that child should be treated. We have to do so in 3 hours. And so for that first quarter, you can see we had 238 emergent situations, wherever those consumers may reside or be. And we, at 100% of them, we were able to resolve or at least have a disposition inside 3 hours. For the adults, there was 1,220, and we were able to render disposition in 1,218 of them within 3 hours. So our metrics are pretty high. They keep us in compliance with our contract with the state. If you turn to page C3, it speaks to the total number of Medicaid beneficiaries who are receiving services. There's 143,000 in Macomb County. That does not include My Health Link. If you throw My Health, this is just a Medicaid report, you throw My Health Link in there, and now you're talking about 183,000 Medicaid people in Macomb County. We service around 14,000 a year. Again, this is just an indicator where it says 7.76. That does not include Healthy Michigan Plan consumers. It does not include the general fund. I don't believe it includes the autism or the HAB waiver consumers as well neither. So we're servicing around 14,000 people. I'm going to stop there. Any questions relative to the report? And if not, then kindly ask for a receive and file.
Susan?
Thank you, Mr. Chair. I'd like to make a motion to receive and file, and then I'd like to speak if I could.
Motion from Susan, support from Joan. Susan, go ahead.
Thank you. First of all, congratulations to the staff. It's a very good report. Very nice to see some good numbers. John, if it's possible, I would like to see these benchmarks. I'd like to see how they compare to peers, too. I mean, I know that it's a stellar report, and it's great. I think everybody on the staff is really good about always looking for ways to even be better than the numbers that we're hitting, and always look for ways to improve. You know, even just the suggestion about the address today. I mean, we're not required to do that, but we're just trying to stay ahead of the curve on a lot of different things. And I would like to see us talk a little bit about that. So I commend everybody because it's a great report, and the numbers, I like when I see those audits and those benchmarks hit. So.
Thanks. If I, maybe Jim, if I can defer to you. Jim, are you aware that the state puts the benchmarks up for all the PIHPs so we can look at that comparison and how we compare with the other PIHPs?
Yeah, I'm not aware that they actually publish it. We can check on the website to see if it's out there, but it may be something that could be available to us.
Yeah, and I don't think we have to do like an everything. I mean, I'd like to see us compare, especially with all the metrics at the end, compare, and I'm not saying we have to do every single one of them, but let's pick the 3 that we exceeded by the most and keep doing what we're doing on that track, and then pick the 3 that we want to improve on, and just, or something, you know, like that. I'm just thinking of trying to get a continuous improvement process.
Yeah, when
but
we
it's
do
a
comparisons,
great report.
We'll often pick comparable counties in terms of population,
Exactly.
Medicaid population, to try to get some apples to apples comparisons, so we can do that.
Yep, that would be great. Thank you.
Lou? Or are you still just on my board? Okay. Does anybody have any other questions or comments? All right, seeing none, we have a motion and support. All in favor of receiving and file signify by saying aye.
Aye.
All opposed? All right, next is a receive and file for Macomb County Community Mental Health, PIHP, Community Mental Health Services Program 2017-2018 Strategic Plan. I'll take a motion to receive and file. Motion from Joan, support from Susan. Go ahead, John.
Thank you. I'd like to spend a little bit of time talking about what we have available for our future and what we should all be optimistic about relative to Macomb County Community Mental Health as a PIHP and a CMHSP. So this too was presented before the Board of Commissioners, not the entirety of it. I gave them the entire document. I didn't go through all of the goals. I would like to go through all of those goals today, or at least those strategic ideas, and to be mindful that, you know, this is just like a 50,000 foot, sometimes I look at this, and it's not intended to write the goals. You know, I have content experts in each one of these areas who will write the goals and move the system forward. I'm not going to write the goals and be that specific. What is not in the plan, and I think it's important that I tell you this in advance, what is not in the plan, but is what is inferred to, it's inferred within, is there's a lot of information and a lot of business that we have to do on the administrative level that isn't even spoken in the plan. And I think it takes a little bit of just time to be able to really, you know, understand how much is in the effort that we have to do administratively, but is not necessarily in the plan. We brought to the board, and I'm going to start just list some of these. It's not all inclusive. Important here. We brought to you before, though, the information technology and information systems upgrade. That's not specified in the plan here today, but it's going to be a considerable work effort on the IT department to bring forth the upgrade continuously on information systems, hardware, software, data reporting, all of our contracts with the FIA and other software companies that are helping us be able to manage our population health and our data. What is not in the plan, as the board knows, is the development of the business management contract for 2018. And somewhere the board has a work group. You know, that's not specified or spoken about in my plan, but it's one of those administrative things that's going to take a heavy lift to be able to work with the board, our entire administration, our legal departments, to be able to bring forth a contract that we can offer up to our providers that's fair and is going to meet the interest of the providers, ourselves, and most importantly, the consumers. What is not in the plan but inferred within is the MORC transition to a fee-for-service contract. That's a big deal going on right now. The strategy for the redesign of the UBHC is not specified in here. The development of the required Children's Crisis Stabilization Program and mobile outreach. We have to have that up and running by the 1st of January. That's not spoken to in the plan, but it's inferred within. What is not in the plan is an analysis of the direct care workforce and the direct care wage pass-through. It's going to take 3, 4, 5 staff, probably 4 months, to figure out how to get those dollars passed through to our direct care workers. That it took effect October 1st. And so we started paying those folks the 50-cent wage pass-through. What is not in the plan is utilization management of CLS, our responsibility for emergency preparedness rules as the Community Mental Health Services Program, a federal initiative, the managed care regulations that have changed, and a lot of the requirements relative to local dispute resolution, appeals, Medicaid fair hearings. The Flynn Foundation grant is not in the plan, but we're going to continue to do that. The Child Parent Psychotherapy Collaborative that we just were awarded, that's not in this plan, but we're going to do it. It's inferred within. Concern for recipient rights protections in a qualified workforce. We keep looking at that all the time. How can we, you know, assure more qualified workforce and work with our consumers on recipient rights protections? You have a meeting coming up, I think, on October 31st, if I'm not mistaken, or 30th. That's 30th. That speaks to, Mark's going to help us out with some of that. Concern for direct care wage retention, or staff retention and a workforce. Concern for the living conditions in the group homes. The board does a gallant effort on making sure that through our property management efforts, that we offer up the best that we can to our consumers for group homes. What is not in the plan is the management of the properties and 130 leases. That's inferred within. The strategy for retaining staffing. We are losing staffing, credentialed staffing, quicker than we can hold on to them. And we're trying to work through that through HRLR and through our own initiatives to retain a workforce of people who just, it's competitive out there, and we're doing everything we can. Every week or two we lose another administrator. What is not in here is the auditing, the Medicaid audit, the compliance audit, the HSAG audit, the information system capability assessment testing audit, the county finance audit, the audit with the Michigan Department of Health and Human Services, and all the preparedness for that. That's not in the plan. Countless additional administrative responsibilities and mandates that come down, every 3 or 4 weeks, it seems like, from the Michigan Department of Health and Human Services. And also, lastly, but not all inclusively, because I could probably list off another 2 pages of what's not in the plan, is that our administrative staff do an awful lot to support the Department of Health and Human Services on various committees. And we also do a lot to support the Board Association. We go to Lansing and support children's committees and membership services committees and all the various committees that are out there. So that's not not in the plan, but it's inferred within. So what is in the plan, and I'm happy to say, is we start off with our mission statement, so everybody understands our mission statement and our values and why we all sit here as an administration and a community and a board to be able to promote the best in the way of treatment and services to our consumers. If you turn the page to, I don't know what page you're on, page 4, I did that schematic. I passed it out too. I think the audience has it as well too. Quickly run through that. We have 7 contracts. That is the mainstay of our business right now, and we can't take our eye off our contracts. So on the left side is the My Health Link. As a reminder, CMS is the Centers for Medicaid and Medicare Services. That money flows straight from the federal government right to those 5 integrated care organizations. They're all Medicare Advantage plans, and they're supporting Medicare and Medicaid dollars, the integration of Medicaid dollars. We're a federal demonstration. We're one of very few in the state of Michigan, and that's a big deal. I always like to use that and coin it, that that's a big deal, because not everybody's doing it, but the whole state is paying attention to what we're doing relative to the My Health Link demonstration. So those monies flow from those 5 ICOs to the PIHP. These are all shared risks and shared savings contracts. So if there's any savings there, we can pass those through to the next year so our consumers can benefit. And if we fall short and spend too much, then we have to find our equity for the shared risk that's involved with it. On the right side is the 1915 BC concurrent waiver. That's your Medicaid contract. That's about $160 million. It flows to the department, and then it comes to us. And then the state general fund, really didn't know where to put that, but I threw that in there as well too. The general fund contract down in the right-hand corner there is our public safety net contract. So all in all, we have 7 contracts, and those are the majority of our funds, not to include the substance abuse block grants and related finances, and I'm going to speak to that in a little bit. So as a region, as a PIHP, we operate as a PIHP where we contract a lot of those services out. The majority of those services are contracted out, and then the minority of them are operated through our community mental health services program on the left side of that sheet. So I think it's always useful to take a look at that. It gives you a real quick idea of where the monies are coming from and what our expenditures, where those monies go. Organizational assurances, these are similar to what I've used before. To preserve the integrity of the Macomb County Prepaid Inpatient Health Plan and the Macomb County Communal Health Services Program, that we preserve both of those in the interest and well-being of the people of Macomb County and those who we serve. And I'm not going to read those other organizational assurances other than we need to be mindful of them. You've all read them prior to this board meeting, and to be mindful of what some of, I believe, are organizational assurances, and what the board should also be convicted are organizational assurances. You can welcome to stop me anytime you want. I'm sure you will as we get through this. Number 1 goal is to perform in compliance with the requirements of the Michigan Department of Health and Human Services 2018 Medicaid Managed Specialty Supports and Services Concurrent 1915 BC Waiver Programs, Healthy Michigan Program, the Flint 1115 Waiver and Substance Use Disorder Community Grant Programs contract. That's the contract that we have with Macomb County as a PIHP, and all the administrative assurances within. If I were to sit here and to itemize or to provide a stepwise progression of how we manage that contract, I may as well just hand you the contract, because the contract is about 150 pages, and you've seen the index before, what our requirements are relative to reporting, to provider network management, recipient rights. The index page is, I think, 15 pages long. So from my vantage point, and I'll continue to be convicted this way, if you're contracted with an entity who gives you money and you have a contract for 1 year, you better perform within the guise of the contract. And if not, you may not get a contract for the subsequent year. So I think it's important for all of us as a community and a board and administration to not take our eyes off the real prize. And the real prize is continuing to be viable as a prepaid inpatient health plan, a PHP. And that's our number one goal. And then our number two goal is the Community Mental Health Services General Fund contract. We are required, and we need to continue to offer a minimum viability of services to those people who have no insurance. They're still out there. Some of them are not in Healthy Michigan yet. And we need to offer them services, and when necessary, that they are at risk to themselves or others, and we have to provide them with acute inpatient hospitalization, then we manage that contract and we pay for acute services. When they can't afford their spend down, then we pay for their spend down or put them at risk. Not everybody's spend down, but some consumers are in a group home. They never will be able to support a spend down, but I can't put them on the curb. We can't do that. So we use general fund dollars to support the safety net so they're not out on the curb. There's a number of ways that we use those general fund dollars, and we need to continue to make sure that we uphold those two contracts. Now, those are the ones from the department, and that's what we've all been doing for many, many years. So those are the two primary goals that we have. The third goal is to perform in compliance with the Medicare Advantage plans. So you have Aetna Better Healthcare of Michigan, you have Molina, you have Health Alliance Plan, Michigan Complete Care, and AmeriHealth Cataris. Those are the ICOs, Integrated Care Organizations. That's the Medicare, Medicaid benefit that we're offering as a demonstration here in Macomb and Wayne, and then a couple other ones further out around the state. And I think everybody's paying attention to that. The department's paying attention to it. We're paying attention to it. And you need not pay attention necessarily to Section 298. We can pay, as an agency, we can recognize 298 and what the department may offer relative to 298, but I won't repeat what Bob Sheehan told us at the Metro Region dinner meeting the other few weeks ago, is that any willing partner, CMHSP, who wants to put their hand up and be participatory in a pilot, then they can do so. And if you want us to be participatory in a pilot, I'll take that under consideration. But at this point in time, I don't think it's wise for Macomb to put their hand up for two reasons. One is that you run the risk of interfering with your federal pilot, your federal demonstration that you're doing. So why would you want to do a local demonstration, a state demonstration? And the other reason, if you put your hand up as a CMHSP, you take the monies from your Macomb PIHP and you give it to Molina, and then Molina gives it back to the CMHSP, and that just doesn't make sense to me at all. Why would you want to give up your Medicaid dollars to give it to an HMO only to give it back as a CMHSP? And so I don't see Macomb County being a participant in a 298 initiative. We can pay attention to that. There are other urban counties that can do that. Oakland County, they haven't done anything in a while that has been pilot-wise or demonstration-wise, or Bay or Sanilac or Saginaw or Kalamazoo. There's lots of urban areas they could go to a 298 pilot. So for our purposes, our goal number 3 here is let's pay attention and work collaboratively, with the administration that's running the My Health Link demonstration. That's an important goal for us, and it's going to run now through 2018 through 2019 and 2020. So that's a big deal for us. And then fulfill, number 4 there is fulfill the substance use and community block grants as well. So if you turn, and I'm not glossing over them because I want to come back, you turn the page to page number 5 there. Now I've listed out your revenue, so it's conveniently looked at, that it speaks to the PIHP and the CMHSP and our goal to be financially solvent. And we've come a long way in a year. We all have to admit that from where we were a year ago at this time and where we are right now, we've come a long way towards financial solvency. All of these figures that you see here, from the $146 million that we're receiving in state plan and B3 services, along with the $18 million in Healthy Michigan plan and the $8 million in general fund, are all projections on revenues that we're going to receive. There's about $2 million coming in from the Medicare Advantage plans that are coming in. And at the time I was writing this up, I probably didn't capture everything, nor was it intended to be so. the community block grants and the number, I think there's 11 grants there that the Office of Substance Abuse is going to have a responsibility for that meets the needs of our substance abusing community. And as a reminder, Randy and his team are putting together a community forum on October 30th. And it's related to opioid crisis and related types of issues that are going on in our community. So put that down for 6 o'clock for October 30th. And I think you already received an email, but you'll get another flyer as well, too. So we look forward to that. So number 5 is financial solvency. I think we have the strategy for that. We've put the budget before the Board of Commissioners today. They receive and file. It goes back to finance and go to the full board. And then we have their support. They throw in a little bit of money for us. Most of our dollars are Medicaid. They throw in about $1.7 million in Medicaid drawdown, in Medicaid match, $2.2 million in general funds that they just draw down dollars to support some of our programs. We've asked for the Crisis Center, for them to give us $286,000 to support Crisis Center operations again, half of those. And then I think another $240,000 to support our general fund operation. Do you have a question, Nick?
Yeah, John,
Go ahead, Nick.
I don't see broken out in here, and maybe it's here somewhere, I don't see it, but the county, you just talked about the county money. Is that like included in the general fund? Or
No. No, that the 8.141, that number was the amount that was appropriated to us from the state, less the $5 million holder for that we received from the legislature.
So in this list, we don't have the 5 million and we don't have the county? In this particular list?
No,
not,
you don't have the 5, because we have the $5 million as a holder. It's interesting because it's general fund state dollars. That's a holder for Medicaid, only to be used for our internal services fund. You can't use it. You can just use it as a holder there. And the other monies I think you're asking about, that way I went to the Board of Commissioners.
Well, the county has a match.
Yep.
And that's what, 5% of the general fund dollars,
Right.
right? So that would be like 400,000, and then we've requested some additional ones. This is just a list of revenues, not expenditures.
Right.
So those, if we were gonna have a complete list of revenues, we'd have to add the 5 from the state, because this doesn't tell where it's gonna be used, just the money that's available. You use Medicaid fund money for non-Medicaid purposes either, so.
Yeah, it wasn't meant to be a financial report. It was meant to be a snapshot, to give everybody kind of an overview. But you're right.
I understand what's here. I'm just saying I don't understand why those two are missing.
The $5 million is not on there.
And all of the county money is not on.
The county monies are need to be approved by I believe the county monies need to be approved by the by the Board of Commissioners yet.
Okay,
but they're
so
not in
those
there.
are not yet
Right.
appropriated, but the 5%.
That's not in here neither.
That's not in here, but that would be like 400,000. It's 5% of the 8 million.
There'll be a 1.7 Medicaid match. There's a 2.2 drawdown, and then there's 287 for the Crisis Center, and I think 246 is just general fund appropriation. Matter of fact, I can give you those numbers. I do have my cheat sheet right here.
That's okay.
Oh, exactly as I just said.
It's not life or death. I just
1.7, 2.2, 287 for the Crisis Center.
I thought it was 5% of general fund was with the county match required by state law. Where am I getting
I think
confused?
it's 10. Cindy Mac, do you know?
Is it 10%?
Is it 10%? Yeah.
10%, but it's 10% of the general fund, not of the Medicaid dollars.
Yep.
Okay. And the other things he's talking about are part of that or in addition to that?
They would actually be part of that 2.2.
2.2.
The 2.9 million drawdown that we went in front of the board today.
Yeah, I'll talk to you later. Okay, I'm confused, but that's okay. We can get this.
So-
That's not pertinent to this. That's fine.
So again, it wasn't intended necessarily as a financial report, but you have some good questions there. Then item number 6, we always talk about integrated care. There are 8 health maintenance organizations, HMOs, in the Michigan Prosperity Region. I'm sorry, in the Metro Region Prosperity Region. And so we do the minimum amount right now. We do what is required by contract, and we integrate care and show proof positive to the department. Pretty, comprehensive report back to the department as a performance measure that we integrate care for one consumer for each one of those HMOs. And I think that, we're in the 21st century here. We ought to be doing, 200 consumers, not 8. And so I'm challenging a few of my staff, administrative staff, who are responsible for integrated care, to come up with a plan to do far better than integration of 8 consumers, integration of care with 8 consumers. I'd like to see 80 to many as 200. So when you talks to the depth of what the strategic plan offers, it doesn't have the strategy how to get there. But the content experts who have the understanding of what additional staffing would require, what additional resources may require, how we do the data metrics, how do we bring those HMOs to the table. I'm going to call upon my administrative staff, some of them who have that expertise, to give me a strategic plan on how it is we're going to get from 8 to 80, in 1 year. So in each one of those HMOs, we'll integrate care with 10 consumers. So it's a 10-fold increase. Any questions, Nick?
Yeah. In this piece you're talking about, this is the Medicare, this is the demonstration project?
Nope.
No, this is not the demonstration. No. Oh, okay.
It's a contract in our it's a requirement in our PHP contract.
Okay.
To show effort towards integrated care.
Because the demonstration project is voluntary, which explains, I think, why you have lower numbers of participation.
Right.
This is different. Okay,
Right.
Gotcha.
So you're going to see this go from, if I have my way, we're going to go from 8 to 80 this year, and we'll go to 200 next year. Then number 7 is the systemic readiness for the home and community-based services waiver. Again, I was debriefed on this yesterday for about an hour, and just trying to grasp the depth of what the home and community-based services waiver means to our consumers and our system of care. And, I can't even begin to, regurgitate that back to you. It's so technical and so laden with work effort, that makes sure that any consumer, let me back up, any provider in Macomb County Community Mental Health shall pass an attestation in what they call heightened scrutiny, an effort towards heightened scrutiny. And if your program, your group home, doesn't show heightened scrutiny, then you will not receive Medicaid dollars, and you won't be able to serve consumers in your home. So the heightened scrutiny really comes down to, if I can just paraphrase it, to community inclusion, to ensure that consumers have choice. I think there were 7 items. They seem kind of funny, but where consumers can have locks on their doors. Imagine that the consumers can have a lock on their bedroom door. A consumer can invite their friends into their house anytime that they want to. They set their own bedtime. There are really not too many rules in that regard. The consumer, you go to bed whenever you want to. You go to the refrigerator wherever you want to as well. And our consumers are also allowed access to food when they feel the need that they want to have a snack. Consumer choice of who they want to live with. So there's a lot of challenges that are going to be upon us for the group homes that everybody needs to pass the survey relative to consumer choice and what the consumers, are they fully included in the community, and as well as do the group homes all pass heightened scrutiny. This won't apply to acute psychiatric inpatient and a lot of your clinical services. It's probably not going to apply much to your CLS services. that are being delivered in the community home, the family home. It will apply to some that are living in their own apartment. They want to make sure that consumers are fully engaged in the community. And if you don't meet the heightened scrutiny test, then you're not going to get the Medicaid dollars. I think well, that's why it's in the plan. It's a significant challenge just to be ready for it. It's going to go live, perhaps. The department may want to go live in 2019. The federal government says you don't have to do this until 2022. But Michigan is staying on the fast track to do it in 2019. So the content expert, we have a contractor, and his sole job is to follow the moving parts on this, and he is going to set up a task force and begin to strategize how we make sure we comply with the home and community-based services waiver. And you've heard about this for a couple of years now, and how we can get more transparent to the community, hold more community forums so they also understand what the requirements are, as well as the providers too. Because what I'm not willing to accept is complacency on behalf of the providers. The skill building, and let me use that as an example, the skill building programs. It's conceivable and likely that the 600, 700, 800 people that we have in the skill building programs may not be able to go to skill building anymore. They may not be able to go to a facility-based skill building program because it's not going to meet the intent of the waiver. And I'm not saying that all inclusively, because some consumers do go to a skill build program and then they go out on supported employment or follow along services, or they go out to vocational services. I think what is at risk, though, is those consumers who are in sheltered workshops, if I can use that just loosely, that they're in sheltered workshop, that probably may not last for very long, that's going to be okay for a consumer to be in sheltered workshop. Unless that sheltered workshop also allows anybody else in the population to go work in that workshop. And then it would be more community inclusion. And what I'm not content with is any complacency of the sheltered workshop to say, well, this is really going to get too much, so I'm going to hang around, for a year or two, and then I'm just going to close up shop. Well, that doesn't satisfy me at all. I've heard rumors to that effect, but that leaves 200 or 300 of my consumers with no transition plan. So the attitude is not only the group home providers, but more so the shelter workshop and skill building providers. We need to develop a strategy on what it's going to take to offer more micro enterprises, more vocational, community-based vocational services, where the consumer is meaningfully engaged in the community, and follow along services, supported employment, and those types of meaningful work initiatives, and not leave a consumer in a group home or in a sheltered workshop. And if the attitude is to walk away from the workshop 2 years from now because the lift is too heavy, then we've just failed the 200 or 300 people in that workshop. And we can't have that. So we got to get the workshop folks on board real quick. So the home and community-based services waiver, stay tuned to that. We've been talking about it. It's our future. It's the way of our future. It's going to change the way we do businesses. So that's a big deal. Did I write all the goals and the objectives and the steps? Nope. Do I expect that one of my staff will do that through committee work? Yeah, we'll get it done, and we'll create the committee, and then we'll develop the task force, and we'll educate the community along the way too. So that's a big deal. Pursuit
Susan,
of.
Hold on one second. Susan, did you have a question?
So, yeah, and I apologize. I don't want to, I'm not sure where to place my questions because I want to make sure that it's timed rightly. So I understand that the strategic plan that you've laid out here, and that it's, in the 50,000 foot level, right? And that you would never, but at what point will we take this template and kind of expound on what's under each category? And where are you going to list that you're going to go from 8 to 80? And at what point do we do that? And at what point do we have that? And at what point do we list those measurable goals? And then at what point do we go back and look back and say, yes, I hit it,
Yep.
hit my mark, or no, I didn't? I mean, it seems like we're always required to file these strategic plans, and rightfully so. And I know that we collectively, the staff internally, have their own goals and benchmarks that they're trying to hit. But at what point do we ever go back and say, well, did we make that mark? I mean, where do we write that down, and where does it come? I mean, is that just in your performance planning with your objectives for staff? Does that ever come to the public?
Well, I think it'll, when we go through committee, that eventually you'll see the stepwise progression on how that's going to happen. You know, if I go to the next one, for just by example, NCQA accreditation, we have been slowly, you know, reading the manual, not slowly, it's just been a long time. We've been at it for a couple of years, reading the requirements for NCQA accreditation. You know, if you're going to be a PHP in the future, and if the HMO is going to pass dollars down to you as an administrator of as a managed care organization, then you have to have you got to be certified as a National Committee for Quality Assurance. So I have another administrator, and his sole responsibility, we use him for other things too, but the sole responsibility that he was brought in to help us in is to ready our agency for NCQA accreditation. A lot of it is utilization management practices. Much of it is related to customer services and appeals and grievances, and what the policies that have recently come out related to the managed care rules, as well as NCQA and what's being completed through our policy, through Kimberly's office and policy development, continually nudges us closer to being in position to do NCQA accreditation. So I spoke to the administrator in charge, and I told him I wanted by July 1 to have a strategic plan relative to NCQA accreditation, and when we're going to have somebody on site, you know, doing that study for us. And they'll do a 6-month look back. So we have to have enough of the meat and potatoes in place to do a 6-month look back. So, you know, I can bring to the board the NCQA plan to you. It's not my role or my position here to put it before you now, but in light of your interest, you know, I can bring more refined strategic goals on each one of these as I encourage my staff to develop those. And so the NCQA one is one of those that we can bring back in. We can bring every one of these back in.
Yeah, I mean, I guess I'm just trying to put myself in the seat of the public or of the Board of Commissioners or any new commissioners that walk up, or any of those of us that are a little absent-minded and need to say, now, what was it that we were trying to do there, and have a document to go back and look to, right? Because this isn't my day job. It's very important to me, but it's not something that's in front of me every day like it is, you know, for you doing this every day. So, but I feel like this is a good high-level look, but will this document get pages behind it that say, you know, more specific measurements, so that it is all contained, so that when we have to go to the Board of Commissioners next year and we say, okay, this was our high-level strategic plan to, you know, accomplish this. This is what we set out. This is what we measured. This is how we did it. This is how close we got.
Absolutely. I think through, you know, no doubt through committee work, mind you, I'm one of about 88 administrators that, you know, serve the PIHP. I think we have 88 in our building. And I have 12 directors. And so a lot of this gets handled, you know, handed off to the, you know, business director. The business director is going to put together the contract and bring a contract forth. The medical director will help us with integrated care to be able to work with the team, develop the goals and the objectives, and say, here's a more refined look at how we're going to do integrated care for 80 people in the next year. So, you know, picking that up and doing it, you know, on November 1st may not happen, but the stepwise progression and how you may be able to get there, you know, middle of next summer, where we're closer to 30, 40, 50 people who we're doing, you know, comprehensive integrated care for, that's attainable. And if we hit our mark that we're doing 80 a year from now, then, you know, that would be pretty successful on our part. Through the staff, we'll be able to put the goals and the objectives here and bring it back to you.
Okay. And I guess I just want to be clear. I'm interested in how you would go from 8 to 80, right? in discussion, but I don't expect to see that in a report. What I do expect to see is that you want to get from 8 is where we're at now, and 80 is where we want to get to, and I expect that the measurement of a year from now, I'm going to see if I'm at 80, and then a year from now, I want to see, did you make it to 80? I mean, it's kind of that compressed, almost executive summary
Yep.
that I think is important to put into this plan. That's all I'm really looking for.
It'll be an embellishment of the current plan. This plan is, as you receive and file, I will embellish upon it later on.
Okay,
Yeah, sure.
thank you.
I would expect that, yeah. Then item number 9, which may draw some of your attention, is evaluate the position of a CMHSP versus a mental health authority. We've never brought this before the Community Mental Health Board. We have, but it's been a long time ago. The last time the board looked at Community Mental Health Authority, the strengths and weakness, or just evaluate our position as authority, was in 1997. And so here, 20 years later, it's my position as the CEO that we just evaluated. I'm not biased one way or another, whether we should be or shouldn't be. I think that we should have a comprehensive study. We don't know what the federal government's going to do relative to Medicaid block grant. And I already discussed that earlier today. I think, if it comes through as Medicaid block grant funds and the state's solely responsible for all the dollars and no federal share, that's going to end up like a piece of Swiss cheese, because everybody's going to take their digger and cut a piece out of that and say, I need these Medicaid dollars for my programs. And I think the benefit, the community benefit through a Medicaid block grant, is going to be seriously reduced, or potentially reduced, comparatively to what we're seeing right now if it comes out that way. But we don't know if it's going to be a Medicaid block grant or not. We also don't know what's going to happen with 298, even though you heard me speak earlier that I don't think we're going to be part of the pilot program for 298. So let's just put that as a sidebar. I've heard more than once that there's a committee that's done a study that, based on some of the previous legislation that's passed, that the general fund is going to be hit by about $4.5 billion to support previous legislation that's been passed on roads bills and infrastructure. So of the $10 billion state general fund, I'm hearing there's a report out there waiting to get my hands on it that $4.5 billion of that dollars is going to get ate up in other areas. And so I have concern for our necessity to meet the needs of the consumers. When you have less state dollars, you have less Medicaid dollars, and a lot of it's certainly unknown. We need to continue to look out for the interests of the 14,000 people that we serve. As a board and then as an administration, that we need to be able to say, what is the best guess, or what is our best position as an agency to evaluate the future? And I don't think we can do it alone, or nor do we have the capacity to do it all by ourselves. I think it's important at this day and age, and the board did commission before internally a review of the pros and cons of becoming an authority or not back in 1997. I think it's time we do it again. What I don't know, and what I don't have for you right now, but would bring to you, is what that engagement would look like, because I still need to be able to determine what I would either want a health advisory group, or what the board may choose or not, to have a health advisory group, something like Health Management Associations of Michigan, or a legal firm, come in and do an analysis of maybe what are the moving parts on the federal level, the state level, the nimbleness of the marketplace, will HMOs, working with county governments, whether or not, we are in better position to, be an authority or not be an authority, as far as, there's all kinds of, values that go into an authority or not an authority, the marketplace, what the healthcare industry is going to look like, and then draw a conclusion. We'd also have to do an analysis of what it would cost, because we don't have a human resources department, so we'd have to pick up human resources, and we'd have to pick up uncompensated liability, maybe some of those things relative to insurance and liability insurance. We'd have to pick up legal, claims payment, those types of things that we don't do now, and what it would cost for us to, even potentially consider an authority, and what the Board of Commissioners may be willing or not willing to do relative to, matching our Medicaid dollars. And I think that I would ask that once the construct of the engagement is put together, what I don't know is how much it would cost. Do I know it was, would I ask you to do it right now? I don't know. I won't ask you to do it right now because, to consider an evaluation, because it may be $80,000, it may be $480,000 just to do the engagement. I don't know. But what I would do, and probably in the next 90 days or so, if I can get to it, bring back to the board what I believe would be the question you would want, all the questions in the construct of the engagement, what you would want answered by a health industry that can say, here's the benefit of becoming an authority, here's the benefit of retaining and maintaining yourself as a community mental health services program at PIHP, here's the risk of action, and here's the risk of inaction. And then be able to say to you, at least get the engagement done, and then take it. Then once you get it, you may say, I don't like it, and you may not take any action on it at all, which is fine. I think you should have the information in front of you, not for the administrative purposes, even though I'm convicted, and I think my staff are convicted that we should do the evaluation. I think it's wise for the board to do the evaluation, just so you know what's going on in 2017, and then take it or leave it. That's one of.
Sorry, I didn't mean to cut you off. Thought you were done. You got a couple questions. Linda and then Nick.
I would think that we shouldn't bear the full financial part of that the county or the executive's office should participate in whatever that cost is. It's they should be a partner in that study, I would think. It's my suggestion. I don't know. My other question is about the integrated care. I know at one time UBHC was kind of looked at in terms of the great hope for a place where integrated care would take place. So you didn't mention that's, now I know we've scaled back on UBHC. So is it still your intention that we revisit that being a place for integrated care down the road when it gets reconfigured and stored up or whatever it needs?
To the question, even though I said with those, one of our performance measures in our contract is to show integrated care with 8 HMOs. That's one thing that we do. We can do a lot better. We also do integrated care at the UBHC. We have My Health Link. We have My Health Link, which is an integrated care initiative. We have My Care that is at First North. We have a staff person implanted at Henry Ford Hospital ER. We have lots of integrated care initiatives that are going on, and we can continue to accelerate them. The UBHC, I did speak about that earlier. We can continue to do integrated care there as well. It was just that one niche place in our PIHP contract that says we need to do integrated care with HMOs for one, and we can do a whole lot better than that, was my point.
I did think that integrated care had to be 24/7, so that's why it triggered that. If UBHC has scaled back, it can't occur there, but it's not. It doesn't have to be 24/7.
No, it's more along the lines. If you recall the My Health Link demonstration, that the caseworker or the care manager that's working on the behavioral health side is also working with the case manager or the care manager on the primary care side, and that they have a collective plan of service that speaks to the mind and the body, and all of the initiatives that go on within it. And so when there's a consumer that may show up and see a psychiatrist, that the primary care physician knows about that pretty readily. So, every time we discharge somebody from an acute psychiatric inpatient hospital, we send a discharge notice to the primary care physician. So there is a lot of, I didn't mean to say it inaccurately, there is a lot of integrated care that's going on in Macomb County, like other counties, but it's just that one piece that's related to the HMOs. I think we can do a whole lot better than what we're doing. But it doesn't have to be 24/7.
Nick?
In my other life, I've been involved with a number of instances in which there's been a transition from agency to authority status, and just as sort of a heads up there, the biggest problems are transitional, surprise, surprise. There are advantages and disadvantages to authority, there are advantages and disadvantages to agency status. Generally, the trend has been toward authority status primarily because there were multi-CMHSPs within a PIHP, and that made a difference, and because of difficulties between the county or counties, and because there were multi-county CMHSPs. But where the relationship's been good, it's different than when the relationship's been bad. But the one thing I do want to urge you strongly to do in this instance, and you've made some allusions to it in the course of your strategic plan, is to, at the beginning of the process rather than at the end, talk with stakeholders in terms of trying to foresee what problems would have to be answered if we did go down that path. My bias has been toward the agency because it's worked so well in this county in the past, but there are some advantages to authority, like the ability to own property. And that's been a problem with the county, and we've had those discussions. But there are other issues that deal with the transition that if you don't work them out early, or at least know which ones have to be worked out, whether you've reached a solution, you're going to be surprised by them, those sort of the law of unintended consequences. And so I would urge you to make sure that you do this study in collaboration with all of our various stakeholders.
Yeah, certainly. It's not something that, I think the study is important. And, you know, I wouldn't even begin to fathom how, with everything that's going on right now, that we have to do to be able to conform with our PIHP contract, how we could even begin to tackle all of the responsibilities we would have to do through authority. And it would take, you know, I mean, some PIHPs have done it overnight. Genesee County, they did it in a heartbeat.
Well, that's not entirely true. Genesee County took years. They initially disapproved it several times, but it was because Genesee County was one of the ones I was involved in, and it actually worked smoothly because they took several years to work in consultation with their employees, with their board, with the county commissioners, with the provider network, et cetera, to iron out all of the difficulties before they actually did it. And it may have looked sudden, but it's sort of like a Star is Born type thing, you know. You're an instant star after 30 years of struggling or 20 years of struggling. Others have had ongoing problems from the point of the transition because they didn't look at those transitional problems in the process. So don't be fooled by Genesee County. Genesee County was anything but instantaneous. It was several years in the incubation stage, shall we say.
Yeah, they did have, yeah, I agree, they had their HR department, and they had a lot of those pieces already, they already took over on, and then when they did move pretty quick, yeah. So, you know.
But the other question, if I could, and it kind of goes with that, it's a broader question, I was going to save it to the end, and you can answer it at the end, but just to keep in mind is I'm not quite sure I know what, other than this is a motion to receive and file, what the board's role is, what you're looking for from the board in terms of the role of the further development or the detailed development down the line.
Well, from my vantage point, it's just, you know, my administrative direction and plan that I believe that I should will at some point in time in 2018 bring back to you a construct of what I would ask of a health advisory group to evaluate us in the way of evaluating CMHSP versus authority. So once I have the legal piece, not the legal piece, but the narrative put together, so when I send it out to a legal firm or send it out to a health advisory group, at least they know what would send me a bid on. So
that was a broader question, not just on this piece, but on the whole strategic
I'm sorry.
plan.
Oh, okay.
What you're looking for in terms of board input.
Well, I'd like the board to understand, what my sense is for the need of the agency, for the consumers foremost, and then for the staff who are dedicated and also are curious and want to know what the future of the community mental health and the PIHP look like. And so to receive and file for you that I have, a dozen or 11 pretty high objectives here that I think should take our foremost attention, and to receive and file. And if you want to help guide me along the way, that'd be more than appreciated too. Am I answering your question? I mean, if you see something else here you'd like on as a strategic plan, I work for you. Just tell me what it is, and I'll throw it on there as well too. There's not an absence of work, I'll tell you that. Okay. So if I can just wrap up, then, I won't do anything further on the authority, until, nothing's going to move forward until it gets your blessing. So you just have my promise on that. I'm not going to run off and have somebody start, poking around here. It'll get your blessing before I do it, if we even do it. That would be your vote. Then the next item then is my HealthLink demonstration. We need not lose sight.
I'm going to go Susan, and then I'm going to go with Lou.
Thank you, Mr. Chair. Through the chair to John. So what was the general consensus from the Board of Commissioners? There was some discussion or something?
In regards to?
In regard to the strategic plan and the talk about an authority and,
I think it was generally well received. They understood, what our challenge is and our opportunity is to do a Medicaid contract. They had, questions, a few questions, not many, a few questions related to the authority. They had, they felt that we should at least have an evaluation done. I shouldn't say that. One board member articulated that we should, take a look at, have an evaluation relative to authority. They were concerned about the budget more so. They talked about the Medicaid reductions that we received, and they were a little confused, and it was difficult for me to unconfuse them relative to how we received $5 million of general fund, and it was a placeholder for Medicaid dollars for our internal services fund, and why it is that we wanted to go back for another $7.5 million. And the one thing that stuck out with me, and I didn't go with it, one of the commissioners said that, administratively we had inappropriately spent the money on CLS, and I objected to the fact that, from my vantage point, I remain convicted that we have not inappropriately spent our CLS dollars in our funding. And then he corrected his statement and said, well, the department has told you that you've inappropriately, and I got a little bit more firm on that without being contentious, and I said, and I have not received anything to the contrary that we have inappropriately spent our money. We were just cut the funding. So at that point in time, the discussion kind of went back toward the Medicaid ISF dollars. But there's a couple board members who believe that we spent the Medicaid dollars inappropriately. As long as I sit here, I'm convicted we have not, and the department has not told us that.
And I would always argue that our mission is to provide as much service to lead to the independent lifestyle for our consumers to the extent that our budget allows.
Yeah.
And at that time, our budget allowed for us to provide those CLS services, and now it doesn't. And that's kind of where the contention is, and that's kind of how I would describe it to my former colleagues if I had the opportunity. So having said that, but I was just curious to know how they responded to some of the goals that you had laid out here. If, to Linda's point about, should the Board of Commissioners or the Executive's Office be interested in and have input into and have a shared expense and interest in the outcome of this, report, if we were to do some type of a committee to look into an authority, did they express any interest in doing that collaboratively, or?
I didn't go into any depth on that.
None
I
of
just
it,
gave
okay.
them the rationale that I think that 20 years later, we should at least have a better opinion of the risk of action or risk of inaction. And so they accepted that, and then one of the commissioners, I checked, that had Leonetti,
Okay.
had a comment that we should, proceed with it. But I wasn't biased one way or the other. I just said I think
Yeah.
we should look at it.
Yeah, and I share your sentiment. I don't really know enough about the subject to know. I would welcome the study as well, but depending upon the expense of it, I suppose, because I want to be careful that we are careful about how we spend our money. Was there discussion about the UBHC?
Commissioner Toko shared her disappointment with us not being able to keep the UBHC open 24/7, because I know she
Right.
was instrumental in getting it moving forward too.
Okay.
So other than that, I gave an overview. She asked for an overview of the UBHC. I gave that, and then she just articulated her disappointment.
Yeah, I mean, I think we're all kind of disappointed that didn't do what we expected it to do, but I think we've righted that ship. Is that a correct statement? With the adjustments that we've made, we've kind of righted that ship. That's my understanding. Am I accurate in that statement?
Well, it's I've asked Jim and maybe Jim might want to speak to it. I've asked him and the committee to, make it more viable, and so we're cutting the bleeding when it comes to general fund dollars, and we have seen some positive performance out of it related to hospital discharges. Jim, you want to speak to it, or?
Sure. Yeah, as you know, we brought reports in monthly to look at encounters versus expenses, and that's really what we're looking at right now with regard to the financial viability of the program, making sure that the dollars that we are expending are supported by encounters that we can then report against our capitated Medicaid funding versus having to come out of the more limited GF benefit. The services that are going on there, I think, create a lot of value for the community. One of the main pieces is that bridge from hospital discharge to ongoing service, and the ability to connect the consumer who's not been in our system before and is coming out of maybe a first or second psychiatric hospitalization, connect them to the services that they need to hopefully mitigate any readmission to hospital services. So I think we're in the process of righting the ship. We'll have another report at full board with regard to the encounters versus expenses and what that's looking like. As you might recall from last month, things were getting much closer. The graphs were going in the right direction. And now we've got a couple months of experience under the new model, and we're hoping to see that those numbers continue to go in the right direction. We should also start to see some impact to our recidivism numbers and our inpatient hospitalization numbers, and we'll continue to monitor those things and make sure that it's doing what we want it to do.
Okay. That I asked that specifically because you had intention of asking the board for some budget, right? I know you're going to speak to that.
The Board of Commissioners?
Yeah, didn't you ask, you were going to seek some additional funding from the board, and did you do that?
I think I spoke to it earlier
Yeah.
when Nick and I were convening. Yeah.
Okay, all right. And that seemed to be accepted by the board or not?
Well, what this board here,
No, not us. I meant the Board of Commissioners.
correct.
You mean for other programs, not
Yeah, just
This-
general fund. No, not the authority study, just in general
This-
fund dollars. You were
This board,
seeking
I gave you
additional-
a copy when we submitted the budget in June or July.
Yeah.
I gave you a copy of the letter that I sent to Steve Schmigel,
Mm-hmm.
cover letter that spoke to our ask for county dollars in support of $287. Now, this went to the county exec's office.
287,000, right?
287,000 for the crisis center.
Yep.
You got that. 264 for just general fund support, and 1 FTE for jail diversion. That did not make it to the Board of Commissioners. So the
Just
county,
the FTE or the whole thing?
just
just
the
the
just the FTE for
Yep.
jail diversion. So the county executive, we met with the county executive, Cynthia Mack and I did sometime back, and said, and I think Jim was there, others, and said, here's what we're interested in, and where if there's any supplemental extra dollars that the county can support, we want these three things. And then the county exec's office and the finance department says, well, we take all the departments into consideration, and then we carry it forward with them. That did not make it to the Board of Commissioners. And Andre Duge, called out Cynthia Mack during the meeting today, saying, is the jail diversion position still being asked for? And I think she very politely said, we'll get back with you. Don't want to put ourselves between the county exec and the Board of Commissioners.
Fair enough.
So the BOC sounded like they wanted to support it. It's not coming from the county exec as an ask.
Okay. So, yeah, that's kind of my, I just want to make sure that we're very well informed of some of the sentiment that's coming out of the Board of Commissioners as well as, and the executive's office. So I appreciate the recap because that I just kind of want to keep an idea of that so that if I'm.
I think given the weight of the entire, of everything that's going on in community mental health, I thought it was pretty well received. There was some complimentary comments by some of the county executives towards the way we're administrating things. And they rightfully had question and or concern, more so about they don't understand, and it's a difficult concept to understand, a shared risk contract where you hold, $12.5 million in risk reserve and that whole thing, and so.
Well, the Commissioner Birdie has spoken multiple times about how this, we've got this fictitious $5 million that we have as a placeholder, but we really can't spend it. So, I mean, that is a hard concept to understand for anybody. So I appreciate it. But, and Mr. Losi, I appreciate the recap. That is how I understood the UBHC, and I just wanted to validate. So thank you.
I just want to remind board members really quickly that we need to be out of here at 8:30, so we have 20 minutes left. Lou, you're up next.
Well, actually, I had pressed my little button when John was speaking about the possibility of a study on authority, and we've wandered a long way from that topic, but that's what I want to speak on. If we're going to do that, and I say if we are going to do that, what we do has to absolutely be independent, without partners. We are a policy-making board by state law, and if you engage with partners that are part of the ultimate decision, then your study is predetermined to begin with. And by that I mean, if you engage the county, if you decide to become an authority, you need the county's approval. If you include them in the study, what you're doing is not an independent study upon which you're required to make a decision. And it's an extremely complicated situation. For example, if you decide to become an authority, you freeze in perpetuity what the county's match is at the time that occurs. And you then have to replace all of the services that the county now provides. Finance, legal, insurance, etc. And the question is, what would be the county's drawdown number at that particular time? Presently, and my numbers are maybe a little outdated, but going back a year or two, the county's match was $4.1 million, of which the county took back $1.2 million as a back charge for providing us legal, insurance, locations, things of that particular nature. So the consideration is very complex, but it needs to be independent on what this board feels is best for how this board would operate with its consumers. If you start, as I said, to include multiple people who ultimately have to approve your recommendation, you've tainted the study to begin with. So I frankly need to see what our executive officer has in mind before I decide on how to proceed on this, because the complexities of it are extremely complicated and frankly have a very long-term effect possibly on our consumers versus the present manner in which we handle services to our consumers. But I think that would be critical.
Thanks. Great comments, Lou. I agree with you too. If I can just wrap up here then, on the number 10 is the My Health Link demonstration. I can't over accentuate the importance of us being able to continue to have a viable contract with My Health Link. It's a big deal. And then number 11 is, I've already spoke to much of this, but I want to say two things. Opportunities for system reform, and I'm going to rely on, again, on some of my staff. And when I talk about system reform, I don't necessarily talk about PIHP reform, but more so community mental health services reform. I believe, my personal opinion is the PIHPs may not be around as long as we would like them to be around. I do believe that the community mental health services program will be around for a long time. And we don't know, I've already talked about the feds, we don't know about the Medicare, Medicaid benefits, we don't know about 298. I think we'll lose general fund dollars. I think that, there's going to be changes that are going to need to occur over the course of the next few years. We have time. I think that we have to recognize our employees, the administrative staffs that sit here before you, and those who aren't before you. They're some of the most astute people that we work with, that I work with. They're clinically sound, they're knowledgeable, they're dedicated to the people of the industry. We don't always agree, but we always figure out a way to get along. And then my staff, they hold compassion for those who are experiencing mental illnesses and intellectual disabilities and substance abuse conditions. So you have very dedicated staff that's working hard at this, and not to lose sight of who those folks are and what they want to do to help the board be successful. And the last thing, during 2018, we got to engage in very meaningful discussions and dialogue so we can ready ourselves for change, to uphold those programs that we have right now that we value, that offer great benefit to our consumers. As a direct operated services program is what I'm speaking. And those programs that we don't excel at or don't offer great value to people or are too expensive, we need to outsource those. And that'll take time. So back to your, question, Susan, can I put that on a piece of paper today? Nope. But Jim Losey, through his leadership, has been working with the staff to create some early systemic reform and take a look at various models and ideas on what we should retain in the way of direct operated services through a CMHSP and what we cannot. So we have to meet the challenge and we have to embrace the opportunity. And I think you have some of the best staff out there working on your behalf. That's my report.
Thank you, John. We have a couple quick questions. Joan?
Thank you, Mr. Chair. John, I appreciate this report. I understand better what's going to be happening out to 2020. I think it's great you're going to do not a study, maybe not hire somebody but at least we have it on the table that an authority could be possible. Maybe it'll never happen, but it could be. I like the idea, too, of outsourcing. I know it's against the union's ideas, but now's the time that we should start to collaborate together with the regionals, just like when we had our regional dinner, and they said if we all got together and bought toilet paper, what a savings that would be. There's no reason that we can't all get together and do something. That could save us a lot of money if we did something like that. But no, we go to these meetings and we talk about it. We've been talking about going together, about purchasing. Nothing ever gets done about it. Do you directors talk about that when you get together? About going together and buying certain items?
The other PIHP directors?
Yes. Oakland and Detroit.
Not necessarily purchasing we do other collaboration related to acute psychiatric hospital admissions, common.
Well, maybe our purchasing, who handles the purchasing at our organization? Maybe they should get together with the others
I
to
hear
find
you
out.
saying. Goes along the same line of Nick's comment on, buying mass
And
insurance.
that's,
yeah. Okay.
well, mass insurance, fine.
Yeah.
But there's other things too that we can outsource. Thank you, Mr. Chair.
Linda?
Sometimes it's so long after I press my button that I forget. I did forget. Oh, no, I didn't forget. It's the brain, I still got it. The direct, as opposed to direct provided services. The Citizens Advisory Council is looking at that. I think Carolyn asked staff to, the chart that we had one time when Ken DeBosart was chair and we had a committee and it first came up that we would look at it. It was from 2013. So I think Carolyn asked and staff said that they would update that. But we're still talking about it. Where will it occur that we come to a conclusion about the direction we want to go and recommendations for board action? How do you see that occurring so we're not still always talking about it?
We do have some movement going on. There was a recommendation or request for me to pull together a personnel committee meeting so we can do some reclassification of some of our case manager 3s. So we reclassify them. They're a master's prepared caseworker. We want to reclassify them to therapist 2. And I think there's like a dozen of those folks that would help us be a little bit more nimble. And the cost is minimal. I mean, they're just a small percentage, or not even a percentage, on the differential that we pay the 2 of them. So we have to bring that to the board. And it's a matter of just being able to decide, what programs that we want to preserve. There's a idea to do more complex case management or conflict-free case management, and we can talk about that sometime. And we need to move people. We need to, take some of our programs and not fund them. If someone were to come to me and say, look, we need more children or more not administrative staff, more clinical staff to support our children's operation programs, I would support that all day long because I think that they're cost effective and they're beneficial to us. Do I want to continue to support some of the outpatient programs? No, I don't think we should continue. But that's not all one swoop. When you look at outpatient, there's outpatient therapy, there's group therapy, there's medication management, there's psychiatric. There's a lot of different components and a lot of evidence-based practices inside those outpatient clinics too. I just don't think we continue to do the traditional stuff. We're known. And traditional, I mean, therapy, mild to moderate therapy, or even therapy for someone who has a serious mental illness. We're known as a community mental health services program for dealing with complex cases. And I think that's where your mainstay is someday, being able to deal with complex case management, conflict-free case management. Our children's programs are stellar because we deal with the most difficult kids that are out there. A lot of programs can't deal with the children that we deal with. That's what we have to do.
And quickly to Lou.
Well, this is turning out to be a tough meeting for me tonight. We're beginning to lose our perspective, I believe. For example, when we meet with the other 2 counties, they're both authorities. We're not. When they say, let's join together and buy supplies, it would be cheaper if we did that. We presently buy our supplies from Macomb County. Frankly, they can't do that anymore because when they were not an authority, Detroit Wayne bought their supplies from Detroit Wayne and Oakland from Oakland County. Our supplies are cheaper now than if we joined with those 2 authorities to buy anything from toilet paper to God knows what. We're losing we're losing our perspective of what the organization is in relation to what the goals are. Their present goals have changed significantly when they became an authority from what we are as an independent agency. So until you begin to look at it from that perspective, we're missing the point. I don't think I am. What I'm saying is, the question is that until you're not an independent agency, you're not an authority. And they're thinking as authorities, and we're not at that particular point. And frankly, I don't think that's occurring, and I think that's what's necessary. So I said it, and frankly, I think it's important. If you want to think as an authority, become an authority. Until that happens, then you're obliged to think as the agency that you are.
Okay, thanks, Lou. We're going to move on. Thank you for the report, John. Yep, we got a motion and support to receive and file. We already have it. I just need all the ayes to say yes. All in favor say aye.
Aye.
All opposed? All right, great. Received and filed. Other possible agenda items. The only thing I have quickly is this Friday, October 13th, there's a recipient rights meeting at 7:30 at the admin building. Does anybody else have anything? John does. John does really quickly.
Yeah, one more. You know, I had a full plate here, and I apologize for this one. I have approved as the CEO, and I need board support on this, for our medical director, Dr. Hosef, to go to a conference. You know, it's a conference that she feels that she should be at with her peers. It's in New Orleans, and to fly her down there and put her up for a couple nights and bring her back. It's at the going rate. It's going to be a couple $1,000s. I think we have enough money in our budget to do that, and I'd like the board support to send her down to New Orleans for a few days. Name of the conference?
We have a motion from Joan. Support from Linda. All in favor signify by saying aye.
Aye.
All opposed? All right, it's approved. John, do you have anything else?
No, that's all. Thanks.
All right. Lou, real quick.
Fall conference is over on Tuesday, and the full board is Wednesday. Do you want to leave it that way, or do you want to move the full board meeting night? What would be convenient for you?
We'll take it under advisement, Lou.
Well, you don't have much time.
We have 2 weeks, right?
No, it's a week from Sunday it starts.
Okay.
So I
But our
think you need to consider whether leaving it or moving it, say, to Thursday, because you need to post public notices if that's what you're going to do.
Okay. Thanks, Lou. We'll discuss it with Kathy when she's around. Any other possible agenda items? All right, closing that here. Yeah.
Mr. Chair, didn't we have a PR person?
Yeah, we do.
Well, can we get a report from him or her?
Sure.
Thank you.
All right, no more other agenda items. Hearing from the public. Anybody wishing to address this body? I'm going to give you 2 minutes. Anybody from the public? Going once? Going twice? All right, we'll close hearing of the public. With that, I'll take a motion to adjourn. Motion from Susan, support from Joan. All in favor signify by saying aye.
Aye.
All opposed? We are adjourned. Thank you, everybody.